Hello, good morning. My name is Mitch Ellis. I'm a first year nurse anesthesia student at Lourdes University, and today I'm going to be talking about the World Health Organization and their Global Emergency and Trauma Care Initiative. First, we're going to start by talking about the WHO, their history, major battles, funding, and mission. In 1945, after World War II, the United Nations was created, and the goal to create a unifying health organization was set in place. In 1948, the WHO, under the UN, held the first World Health Assembly in Geneva. Some of the battles fought throughout time are in the 60s, they fought the spread of syphilis, leprosy, cholera, and yellow fever in Africa. In the 70s, they fought for family planning research and birth control methods. In the mid 70s, they focused on child immunizations. In the 80s, they were able to eradicate smallpox. In the 80s and 90s, they worked to combat AIDS and polio. In the 2000s, they continued their battle against AIDS, TB, malaria, and measles in African countries. Of course, in most recent years, they've fought against Ebola outbreaks as well as the COVID-19 pandemic. WHO leadership and funding. Dr. Tedros is the director of the WHO, and he was elected in May of 2017 for a 5-year term, and has been since re-elected until 2027. He's originally from Ethiopia, has a history of a master's degree in immunology and infectious disease, and a PhD in community health. He worked heavily in Ethiopia after his education and focused his time in malaria. He then went on to work for the Ethiopian government before taking on the Director General role at the WHO. The mission of the WHO is to promote health, keep the world safe, and serve the vulnerable, with measurable impact for people at country level. The WHO gets funding from many different streams. The WHO is a nonprofit organization, and it has been historically underfunded. In 2018 to 2019, the annual funding was $4.421 billion, which may seem like a lot, but is actually less than many large US hospitals. 79% of the funding from the WHO come from member states and large donors like the Bill and Melinda Gates Foundation. Here in Figure 3, we can see the top 20 contributors to the WHO, and then Figure 2 is Dr. Tedros. The AO Foundation. The AO Foundation was founded in Switzerland in 1958. It was initially an organization based on orthopedic surgery, but has since become more philanthropic. It is a not-for-profit organization, and under it is the AO Alliance, which is heavily focused in low and middle income countries in sub-Saharan Africa and Asia. They've been putting programs in place to decrease disease burden of trauma and injury in these countries. So the Global Emergency and Trauma Care Initiative. It was launched in 2019 with two goals in mind: to rapidly increase capacities to provide quality emergency care in countries around the world, and to foster awareness through a global advocacy campaign about its potential to save lives. It's funded by the AO Foundation. The initiative was the WHO's response to Resolution 72.16 from the 72nd World Health Assembly, which aimed to ensure timely care for the acutely ill and injured. GETI was then unanimously passed in 2019. The aim of GETI is to support mainly low and middle income countries in identifying methods to better develop their emergency care systems. The trauma burden in low and middle income countries. McLeod and colleagues found that there were 2.6 surgeons available for traumas per 1 million inhabitants in low income countries, while in high income countries that number is closer to 59 surgeons per 1 million. They also found that rehabilitation services and post-operative care in low and middle income countries were severely lacking. In Africa, traffic accidents are the leading cause of trauma and injury. Shantakumar and colleagues described that in low and middle income countries, that acute trauma and injury account for more deaths per year than HIV, AIDS, malaria, and TB combined. If that isn't staggering enough, it was identified that trauma in low and middle income countries account for approximately 5 million global deaths per year, let alone the 50 million people that are left debilitated after a trauma and injury. The authors go on to describe that nearly 2 million of those deaths could be preventable with proper access to trauma care. Pre-hospital deficits. Pre-hospital deficits are by far the most prominent issue in low and middle income countries regarding emergency care. Ningwa and colleagues identified that finances were lacking gravely towards EMS programs in Uganda, with no direct funding available. In Tanzania, emergency services are not included in the National Health Insurance Fund coverage, which is why EMS federal funding is abysmal. Mahama and colleagues found that in the Accra region of Ghana, the average response time for EMS was 16.9 minutes. This is more than double the global standards for EMS response time, which is under 8 minutes. A key problem here is that drivers are unable to make it to the scene in decent time because of heavy traffic, and decreased adherence to traffic regulations. The golden hour of trauma is well described in the literature, and it says to get the patient from the trauma scene to a hospital within an hour. Unfortunately, Mahama and colleagues found that the estimated median transport time was 82 minutes. Education and training may also be a factor, as the Platinum 10 is a well-known idea of stabilizing a patient within 10 minutes at the scene of the trauma and then transporting them out. Unfortunately, time spent at the scene was found to be 17 minutes as a median, with a range of 1 to 180 minutes at the scene. Ningwa and colleagues identified that 69% of trauma transfers to the hospital were performed by police. They have no medical training, and they use police trucks, as you can see in Figure 8, which don't have a designated space for a patient. This is because there's no 24-hour EMS available at many hospitals. The staffing deficits of pre-hospital care are echoed in the literature, with Ibrahim and colleagues describing Nigeria and stating that 55% of patients were brought to the hospital by relatives, 21% by bystanders, police brought 5.5%, and only 2.3% were brought by EMS. Ningwa and colleagues also identified that 50% of EMS staff interviewed in their study never notified health facilities that they were going to be receiving a trauma patient. So as you can see, underfunding, traffic and EMS response times, lack of EMS staffing, and poor coordination with facilities are all factors in their pre-hospital deficits. Moving forward here, we are going to address the acute care deficits. The absence of designated trauma centers was found to be significantly higher in sub-Saharan Africa than in other low and middle income regions of the world. McLeod and colleagues also found that fellowship programs are very rare for physicians, and emergency care residencies are relatively new in the areas. Emergency units frequently face shortages in supplies such as ventilators, central venous catheters, chest tubes, and even basics like airway adjuncts, blood pressure, and EKG monitoring. The work of the AO Alliance. So they are heavily stationed in Africa with many new initiatives. In Malawi, they have created 2 new operating rooms built at the Queen Elizabeth Central Hospital. In Ghana in 2020, they launched a 3-year vocational program for plaster technicians to assist medical teams in casting patients with fractures. The AO Foundation and Alliance have also aided in Ethiopia with healthcare provider training, and more recently they just set up shop in Burkina Faso to improve timely access to trauma care. What has the WHO done? So in concordance with Getty, the WHO has paired with the Red Cross to provide education and basic emergency care training to providers in Tanzania and Uganda. This low-cost training has been found to significantly increase skill levels of providers in pre- and post-skills testing. The WHO has also published various things on their website, such as trauma care checklists, protocols for pre-hospital systems, basic emergency care and surgical handbooks, and clinical tools for triaging patients. Finally, the WHO has created an international registry for trauma and emergency care that is free and open access on their website. This is an avenue to increase data collection as well as quality improvement. Being a high-income country, the United States won't really see much of the impacts that the WHO and the AO Alliance are having at the global scale, because our emergency medical care system is quite efficient and robust at this point. Social determinants of health and access to trauma care. So socioeconomic status definitely plays a role, as high-income countries have more surgeons available, faster EMS arrival times, and a more robust infrastructure. The AO Alliance and the WHO initiatives are attempting to equal this playing field in regards to these factors. Alayande and colleagues in 2022 described that the northern region of Ghana, traditional bone setters are used as opposed to seeking medical help. And this is because traditional bone setters tend to be 25% cheaper than going to a physician or an emergency room. Unfortunately, this practice is not sterile, not safe, and frequently entails re-breaking healed bones. In Figure 10, you can see a picture of the work of a traditional bone setter. Geographical location also plays a role. 90% of inhabitants in Nigeria and Kenya have a trauma surgery capable within 2 hours of them, while 25% of the population in South Sudan only have one within 2 hours of their residence. Lack of insurance also plays a role in disparity. Being uninsured in Cameroon was seen to have a decreased rate of admissions to the hospital if you were a trauma patient, and also a delay in surgery. Surgical intervention was more prevalent in the uninsured. A long road ahead. Though there has been great advancements through initiatives such as those supported by the WHO and the AO Alliance, there are still extreme deficits in trauma and emergency care available at the global scale. It is up to us as advanced practice providers to advocate for these underserved populations and be their voice. Thank you for your time.